Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas. Sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes. Thanks for tuning in to the Ultimate Dental Podcast, the podcast where thought leaders, industry experts, and thriving practice owners reveal their very best tips, tools, and strategies that will help you to grow your dental practice faster. Now, here's your host, Dr. David Moffet.
Hi everybody, and welcome to today's episode of the Ultimate Dental Podcast. I'm your host, Dr. David Moffet, broadcasting from Burrowang in New South Wales in Australia. Look it up if you don't know where it is. And today my special guest in Stockholm in Sweden is Dr. Nicole Winitsky, who is actually a real doctor. She's a PhD as well as being a dentist. Nicole, welcome to the Ultimate Dental Podcast. It's 8:30 in the morning there. It's 6:30 in the evening at night here. And it's great to be on the same day with you, but thanks for joining me on my podcast.
Thank you so much for having me, David. I'm really looking forward to this chat with you.
Well, I have been too, Nicole, because you're a very busy woman and a very busy dentist. And it's been a big chase for me to nail you down to a time, and that's one very specific time. But here we are talking, and you've done a lot in the last 12 months, but you've done a lot in your career, culminating with the PhD that you've done. You've also this year, as we were chatting beforehand, you've lectured almost in Australia, in Singapore, and you've now started working more full-time in private practice as well. So tell me about your career in dentistry. Why did you start in dentistry, and then why did you specialise, and what was your attraction to your PhD topic?
Okay, it's been more than 25 years ago now since I started to take this first decision. So I'm going to try to remember. But the reason that I started dentistry was actually that I had a boyfriend who was studying dentistry, and I think that if I would not have met him and seeing him study dentistry, I would not have even thought of becoming a dentist. So I applied for dental school. I thought I'll try that. And then I turned out that I really liked it. I enjoyed it a lot. And after I finished my studies, I actually worked for quite a long time as a GP. I worked for 12 years before I started my prosthodontic training. What happened was that after like 3-4 years after I graduated, I ended up working at, I think at the time, the largest implant clinic in Stockholm. So within that clinic, I got to do a lot of implant treatments and a lot of prosthodontic treatment. And I was at the time not very experienced, but I got the opportunity to work side by side with a prosthodontist who was working there. And I worked there for like 6-7 years, and it was a fantastic time. All the things that I didn't understand, all the things that I felt unsure of, I could always discuss it with him. We discussed the treatment planning. He looked at my preparations. I went with the impressions to him, and we studied them together and talked about what could have been done better and what was good and not. And I learned so much during these years. And after that, I started to feel more and more that maybe I should try to specialize in prosthodontics. But at the time, I also had 3 kids. So what happened was that I went to one of these prosthodontic dental conferences, and I met the whole prosthodontic crew from the largest prosthodontic clinic in Stockholm. And they told me, we're starting now a new residency in prosthodontics. Why don't you apply? And I was thinking, I don't know. My oldest son was 8, and then I had 2 smaller kids. They were 2 and 3 years old. And I was like, oh, I don't know. Maybe my kids are too small. Maybe I shouldn't do this. And then they said to me, no, don't think about that. We have Matthias here. And they pointed to a young colleague. He has 4 kids, and he just finished his prosthodontic training. And then I was thinking maybe Matthias has a wife who is helping out a little bit at home, because I had a husband who was running his own company. And so I said, no, I don't really know. Maybe Matthias' wife is a big part in this. And they were like, no. Matthias' wife is a resident in oral surgery. And then I started to think that, okay, if they can do it, probably I can too. So I applied and I started my pros training, which was really, really a lot of fun. And I learned a lot, and I really got to focus into the area of prosthodontics, where there is so much to learn and so much to understand and so much to know. It's a really, really big area.
I love that thought process that you went through, because a lot of people in life don't do that. They find one reason why something isn't going to be for them, and then they just hang on to that, even though there is a way that they can get what they want. And I've often said, and I said it again today to someone, if it has been done, it can be done. And not so much, running a 10-second 100 meters or swimming as fast as Michael Phelps. Physically, some things can't be done that way. But in business and general business processes, if somebody has done something before, then there is a path to follow. And so the challenge for you was saying, well, they've had more children and they could do it. So if I've got one less child, that shouldn't be a big problem. And I love how you just put that to the side and said, and you focused on your goal, and then you enjoyed the process as well, in getting to where you were then a specialist in prosthodontics. But also, as you mentioned, you as a general dentist, you were well mentored, and then when you did the prosthodontic course, that also gave you mentorship along the way to make it enjoyable, rather than the cream rises to the top and the rest just gets washed away, which is often the case in some educational processes. It's just like, let the smart survive and let the not so smart struggle and die. The law of the jungle in that sort of situation. So now in our conversation, you are now a registered prosthodontist. Where did that take you from there?
What happened was that during the prosthodontic training, we had this assignment to do some kind of research project. So I got to start to work with a project that was started 17 years earlier at the Eastman Institute, which was a group of fairly young patients that was treated with single anterior implants due to trauma or aplasias. And they were treated according to a strict protocol, and they collected baseline data, and everything was done really meticulous. But then no one really followed this group of patients. So my research project within my residency was to look at these patients after 17 years. So I started that a little bit. And then after I finished my specialization, I got the question if I didn't want to put this into a proper PhD project. Because the organization that I was working in was putting a lot of effort into that. They wanted to educate some of the specialists into becoming PhDs. So also, again, after thinking a while, since now my kids were 6 and 7, the small ones, and my older kid was 14. But I also have a fantastic husband that really is supporting me in everything I do, and that also we're sharing everything at home. So that's a way that I could do this. So of course I discussed it with him, because I know that doing a PhD is demanding a lot, both from me, but also from my family and everyone around me. But after thinking, I realized that I would think that this would be a lot of fun. So this research education was in Sweden. It's 4-hour curriculum to become a PhD. Not 4 hour, 4 years curriculum to become a PhD. But I was going to do this in half time, because I was going to do half time working clinically with patients and half time with research. So this was an 8-year commitment that I got into. And what also happened was that I applied they just started a research school that's called the Swedish Odontological National Research School. So I applied for that, and there were 17 dentists in Sweden that was accepted for this school. And we were having an education together, so that 3 full weeks every semester was dedicated to us taking courses together. And this was a really, really good curriculum. There were so great lectures that came there and talked to us. And I couldn't help thinking that it was so sad that it was only the 17 of us that was in this group that got to listen to this fantastic professor in virology that came to talk to us. So that's when I actually decided that I wanted to start this podcast. So I'm running this dental podcast since 2016, which was at the time where I just started my research studies. And my mission with the podcast is to, like you do, invite people with a certain expertise within a certain area, and to talk to them and make it really simple for dentists to just put the headphones in their ears and to learn something new and improve as dentists.
It's a great concept, podcasting, and it's funny. I had somebody doing some work in my property last year, and I said, "Oh, what are you listening to?" And he said, "Oh, podcasts." And I said, "Well, that's not really very specific. That's like reading. They're saying I'm reading the newspaper or I'm watching TV. What specific sort of podcast? Yeah, what's the subject of your podcast?" And but it, for somebody old like me who grew up on only radio news or TV news, and then all of a sudden then there's 24-hour news on television, which is an amazing concept to think that Ted Turner decided that would work, and now it is. And then now there's just news at everybody's fingertips. But the fact of podcasts, and so many people and so many different media are being turned into podcasts for consumption as well. It's really exciting. So as you and I were discussing beforehand, I'm a newbie at podcasting. So tell me, your podcast's been going for how many years, and how many episodes have you done? You're a pro.
I don't do the episode as often as you do. I do about one episode a month. My goal is to do 10 to 12 episodes every year. And I started 2016, so it's coming up to almost 9 years. That's what I'm most proud about, actually, that I've been keeping this up for such a long time. But I really love it. It's fantastic. I get to meet all these fantastic people and talk to them, and I also get to help other people to know more. And I really think that's something that we can't have enough of, spreading knowledge. It's become one of my main pillars, I think, in what I do.
I agree wholeheartedly with you. And since I initially started recording, I did one day where I did 4 podcast interviews in the day, and then I said, no, that's wrong. So I had to actually set my calendar that if somebody booked, then there was only one recording each day, because I remember during that day I said to somebody, as we said earlier, but it wasn't them. I'd actually mentioned what the topic to a previous person, but it's the same like interviewing people for a job, or or even in coaching. If you run multiple coaching calls in a day, did I tell you this or did I tell the previous
Yeah.
client this?
Yeah.
So you do have to have a balance. The person who did the most dental podcasts was Howard Ferran from Dental Town. He did
Yes.
nearly 2,000 podcasts. I think I was
Yeah.
on there twice.
Yeah.
I was his first Australian.
Oh,
Um,
really?
but he also did them uncensored, as they were.
Yeah.
There was coughs, splutters, ums and ahs, all that.
Yeah.
But I take my hat on anybody who had a touch that would be in dental. He interviewed them, but it is a great medium, and I take my hat off to you for having done it for 8 years now, because the longevity of continuation is sometimes, as you would know, as a lecturer and a teacher, sometimes, and even speakers, get tired of their own stuff, and yet people, and a friend of mine who speaks all over the world will ask, how many people here have heard me before? And most of the room hasn't. And so therefore he's basically talking to new people, even though he's telling them the same thing. And if you've got something that you're passionate about and you're a specialist in, as you are with your research, then there's always going to be an audience that's going to be happy to hear what you said. So let's get back to your research, because that topic, when you sent me the title, single implant in the anterior maxilla, that's a very broad range. And then all of a sudden you've now said that it's a follow-up of people who had been surveyed 17 years before. And straight to my mind came those studies of, there's one, I think, famous, of children who were, their progress in life from when they were 5, then 15, then 25, then 35, into adulthood, into retirement. And so this is, again, something that you can always go back to after 17 years, after 27 years, after 37 years, and just see how this is going. So straight away, it's not something static in time. Here's this implant, look how it's going to last. But as we were talking about before, in terms of knowledge, before we came on air, in terms of knowledge and how every 5 years I felt that I knew more than I had, when I was 15 years out, 20 years out. It was just, there's always something to learn. So the expectation that I would think if I was in your shoes was, I can't wait to review these again 10 years down the track and see how they're going.
That's exactly what I want to do.
So here you are. You're going to be like Harry Potter. You're going to be the J.K. Rowling of anterior single implants. So you're just going to keep them coming out. We'll be waiting for the sequel, the movie, the miniseries.
Now, as a few years have passed now, or quite a lot of years, if I would review these patients again in 2026, 27, it would be a 30-year follow-up. How cool would that be?
Oh, that would be great, because we all know that when implants were invented, it was kind of like, all right, this is it. But then we found that they fail for the same reasons that teeth fail. Smoking will still loosen an implant. Bugs will still loosen it. It's not perfect. So this is exciting that we can review these results, and also, I guess you've got new cases that you're reviewing that are going in, and then reviewing them after 5 years, 10 years as well, in terms of the advancement in design, lengths, thicknesses.
I actually do. I have another study ongoing that I'm just going into a meeting about that after this podcast, where we're just doing what you said. So I've been part of the treatment of the single anterior implants in this group, and we've been following them for 1 year now, and we're going to do a 3, 5, and 10-year follow-up on them also.
Sounds fantastic. Now, you also mentioned to me before we started the podcast that you've done research in single tooth implants or single implant tooth replacement in young adults with a mean age of 21. Tell me about that research.
Actually, that is the same research, since the material of patients that I was following for 17 years, they were fairly young. They have a mean age of 21, so it's not as if they were kids. But at the time, they were not. This was 1996 and 1997, and the first single implant ever was placed in 1982. And at that time, it's really weird, but the implants were placed, but there was not a really good prosthetic solution to put on top. So it took a few years, like up until 1989, where they had a solution that they figured that, yeah, this is a good solution. We'll use this for the single implants. But there were still a lot of problems with the derotating screws and the crowns becoming loose. So, and at this time, Sweden was very much in the forefront of doing implants, since Per-Ingvar Brånemark is Swedish, and it was a big thing here. So the dentists here were very cautious in treating younger patients, since we didn't really know this single implant method well enough. But then in 1992, the Cera 1 single tooth concept came to the market. And that's where the Swedes started to feel that, okay, now we have a good prosthetic solution on this single implant. Now we can also start to dare to treat younger patients. So that's why this woman, Kerstin Olgart, who was the head of the prosthetic department at the Eastman Dental Institute in Stockholm, she started this study with a group of young adults. So these were actually one of the first young adults that was treated with single implants. So that's why this is it's a really interesting group of patients to follow.
So let's tell me about the research 17 years on. What was the result of that in terms of subgingival as well as supragingival? Obviously, there will be some recession. The aesthetic result may be not as desirable as was first thought when the implant was put in. What about the stability? I'm giving you three different questions there all in one. What were your findings across the board, and then specifically narrowing down? It was how many people too? That were
It was 42 patients originally in the group, and then I recalled 40 out of the 42 and did the new examination on. So it's not a huge group, but considering the time of follow-up and everything, it's still a quite okay material. But what we looked at a lot of different parameters, of course, because we wanted to examine several factors. But if I should pick out like the major ones, I would say that if we talk about marginal bone loss, for example, the mean marginal bone loss during these 17 years was 0.1 millimeter.
Oh, fantastic.
0.1 millimeter bone loss. But we should also remember that these were the machined Brånemark implant with no anodized surface or nothing. And that could, of course, be one reason. But I think this is really interesting, actually, because when you read research papers, and now I throw out the number 0.1 millimeter mean bone loss, and it sounds fantastic. But if you look at the actual material, you can see that half of the patients have lost bone, but actually half of the patients in the group have gained bone.
Oh, wow.
So that's also why the mean evens out. But there are only 2 patients in the material that have lost more than 2 millimeter bone during this time. So still, we must say that it's a good result when it comes to marginal bone loss. But then one of the important and very, very interesting thing that we looked at that became a paper on its own is that we looked at the degree of infraposition. Because that's when I started this study and I said I was going to look at infraposition. I had a few dentists who came up to me and said, why do you need to look at that? We know that implants end up in infraposition. And yeah, we do. But now we had study models from baseline that I can then compare with study models from the follow-up examination. So by scanning these study models, we could then digitally actually measure the movement that had been occurring throughout this time. So this was really, really a lot of fun to do. And what we found was that, if I just take the broad terms, and what I find is most clinically relevant, if we look at how many patients that had an implant infraposition of more than 1 millimeter, there were 30% of the patients in the material that had an infraposition of more than 1 millimeter. So if that's a lot or not, I'm not really the one to judge. But this also goes very well with other results of long-term studies that has been done. So I think that we can more or less say that we can expect our patients in 30% of the cases to end up with an infraposition that is more than 1 millimeter. And I'm thinking that this is the group of patients that we would like to identify. We would like to know before we do the treatment, who are these patients that are going to end up with the most problematic infraposition. So we actually also tried to look at different characteristics within the patient and within the implant itself, like the position of the implants, to see if we could find anything that could help us predict which these patients are that have the greatest risk of infraposition. So what we found regarding that, because a lot of studies have been discussing this before and looking at it, and it has been discussed whether age and the sex of the patient and the facial type, if you have a long facial type or a squarish facial type, that could be factors that we should look into when predicting infraposition. We could not, in this material, find that any of these parameters would be really important. But what we did find was that if you measure the patient's lower anterior facial height, that's from under the nose to underneath the chin, and the patient has a lower anterior facial height of less than 70 millimeters, then you have a smaller risk of receiving infraposition. And we also found that if the implant is placed in central incisor position, because all the implants in our studies was either central incisor, lateral incisor, or canine. So we found that in relation between these three, if you have the implant in central incisor position, you also end up with less infraposition than if you have them in the lateral and canine position. So that was kind of interesting and fun. But what we also wanted to know was, okay, now we know that 30% of the patients end up with an infraposition of more than 1 millimeter. But is this a problem to the patients? Or are we making something into a problem that maybe not is a big problem to them? So we also did this aesthetical evaluation, and we asked both the dentist and the patients what they thought about the aesthetics of these implant crowns. And it turned out that although 100% of the implants end up in some kind of infraposition, some are very small and some larger, but all implants ended up in some kind of infraposition. The majority of the patients were actually pleased with aesthetics. And when comparing the dentist and the patients, it turned out, like we see in many, many, many studies, that of course the dentists are much more critical than the patients are. So they were assessing the aesthetics as worse. And this is common. We know this from a lot of studies, but I really think that we should also think about this when we meet our patients. That when a patient comes into my office, I see so many things in the mouth of these patients that the patients actually don't see at all. And it's not my mission to tell the patient what's wrong. I think that patients should come to me and say, I think that this tooth is ugly. And then we can do something about it. but I'm not the one who should tell my patient that maybe you should change this tooth because it's a little bit gray or it's a little bit. And I have a really fun example of this from the research, because when I was trying to gather all these 42 patients that I tried to get in for examination, they had not been for a checkup for the implant for maybe 15 years.
Oh, no.
At the Eastman Institute. So, and they were quite young when they received their implants. So a lot of them moved to other countries, or they moved out in Sweden and lived somewhere else. So I really had to investigate to find them. So I started with Googling, and I had this one patient with a very common Swedish name, like Sven Svensson. And I Googled him, and there was several pictures coming up of Sven Svensson. But I immediately saw that that's my guy, because I can see that his upper left central is shorter than the right one. So I knew that that was the implant tooth that had ended up in infraposition. Okay, so I called him up and I asked if he could consider coming in for an examination. And he said, yeah, of course, I'll come in. So he came into the Eastman Institute and I did the examination. And then I started very carefully, but I started to talk to him a little bit about the fact that his left central was shorter than the right one. He didn't have a clue. So this is something that I saw immediately just by looking on a photo, and he didn't even know about it. So I really think that we should have this in our mind when we're talking to our patients, that we should not problematize. Can you say that in English? We should not make a problem out of something that the patients are not experiencing to be a problem. So that's also something I learned. I actually sometimes felt a bit bad that I started to talk about the patients of the fact that their implant was shorter than the other teeth, because that actually made the patients start to think about that more.
Yeah, a whole lot of thoughts going through my head at the moment, including a cosmetic plastic surgeon who works with the female body in terms of helping them to, they come in and say, I'm not happy with the shape of my body, and so they rely on the surgeon to say, well, we can do this, we can do that, we can do this, and sometimes some of the recommendations are what the person actually wants, but they had no idea that they needed it or wanted it. And it's the same in the mouth.
Yeah.
The worst patient, though, as you would know, is the patient who is the reverse, who what we used to call them the mirror to nose. The mirror to nose. I don't like this, I don't like that. And it's like, just go to normal, not even arm's length, because nobody actually comes to you at arm's length and talks to you. It's actually, 2 arms lengths away that people are going to be looking, and they won't notice that there's that variance in teeth angulation. Or I find, as a dentist, I just always look at people's teeth and go, your smile could be better, but they're happy with what they've got. So,
but sometimes I also feel that we teach the patients to worry more or to see more in their teeth. When we do a treatment, I treat quite a lot of patients with need of anterior treatment. And when they are going through this treatment and we have all these discussions, like what is this tooth going to look like? Is the shape good? Is the color good? Is the surface good? The patients start to look at their teeth so much more. And then they also start to see that I don't really like this one, and I don't really like this one. And so this is also something that we are like helping, or maybe not helping, the patients in seeing these things.
Oh, absolutely. Absolutely. And it just depends on who you're talking to at the time, and whether you go down a rabbit hole that you wish you never mentioned. Sometimes.
Exactly.
It can be difficult. So let's talk about you now as an educator and a presenter. We also spoke before we started the podcast about your how much you travel to speak. Every 2 to 3 weeks, you're going somewhere to speak, and your itinerary for a number of places in Europe in 2025, as well as Las Vegas, and there was another place in Asia as well. I think you were.
No, Asia. That was last year, Singapore.
So you don't mind jumping on a plane and presenting and getting the recognition.
I love to. I think if I would have been a dentist who would have been sitting in the clinic and patients only coming to me, and I wouldn't have been able to talk to colleagues and meet other people, I would have been. I would not have enjoyed my job as much as I do now. I love spreading knowledge. I think it's really, really important. And I love meeting colleagues. I learn so much every time. Either I do a podcast with someone or I just meet someone at a conference and they come up to me and we talk about, maybe they say, oh, you do this, I do it this way. And you always learn something new. And it's so interesting to meet people from different parts of the world, because dentistry is really different depending on where you live. So I think my eager and my wish in spreading knowledge, it actually comes from the beginning, that I have a really strong feeling that I think that our patients, they are entitled to have the best treatment that they can have. And in order for them to have that, we as dentists have to have a lot of knowledge about what we're doing. And as you said before, you always you don't know everything, and you will never know everything, and there are always new things to learn, and that's also what makes dentistry such a fantastic work, I think.
So, professionally, with the amount of knowledge and experience that you have in implant dentistry and in learning, what are your thoughts of general dentists doing implants early and often? In my career, I did less than 20, didn't really enjoy the amount of preparation that it took me, and felt that I'd be better off letting somebody else put the bolts in and then I'll just restore them. And that worked much better for me, rather than sweating over, is this in line, is it not? And just, even just simple mandibular and implants and upper premolars, and I never did anterior ones. That's way too much trouble for me. So how do you feel when you hear of somebody who's been only a very recent graduate and they're doing lots of implants? Do you feel that they've got the scope that you have, or do you feel that there may be some questionable treatment going on there?
That is a fantastic question that I really think is important that we talk about. I don't think it's the fact if you're a GP or if you're a specialist. I think that everything we do, all the things that we do a lot of, we become good at. And of course, we need to see too that we are educated within the area before we start doing things. And as you say, when a young dentist, maybe have been graduated for 2 years and you go into implantology, when I see 25 years into my dental career and I see how much I still don't know, I know how much it is that they don't know after 2 years. And I think that maybe that's not enough time to have the experience of treating patients as such, or doing dentistry, to go into placing implants. And I think this is something that, in the beginning of the implant era, there were only specialists that were allowed to place implants, at least in Sweden. Was it not like that in Australia? Yeah.
It was.
Yeah. So I think that it should be some kind of qualification, that you need to be qualified to place implants and to work with implants, because once you placed an implant, it's in there. It's a very, very definitive treatment that we do, and we can't play with our patients. We can't use them as what's it called? Like
Guinea
animals in a guinea pig. Exactly, that's what I meant.
Hamster.
Hamster. I don't think it's fair. It's human beings that we are treating, and we need to treat them as such. And there are too many patients that I have seen that have received like a great huge anterior retraction, and you can see the gray coming out from the implant, or you have an implant placed into the adjacent tooth, so you have to do endodontic treatment on the adjacent tooth, and there's so many things that can go wrong. And it's just not fair to the patients that we don't take our responsibility in knowing that we have enough skills and knowledge to do this kind of treatment. And it seems a little bit like everyone in the dental profession is maybe not taking that responsibility. And then maybe due to that, we should have some kind of way to know who is qualified to treat patients with implants. And I think this should be done from the dental profession, but also together with the implant companies, because the implant companies also it's also in their interest that their implants are working well. So I think this is something really important, and I draw a lot of parallels between implants and working with aligners, because aligners is nowadays coming into the same kind of I don't want to call it probably challenge, same kind of challenge as we've seen within the implants in the implant treatments, because it's something that people earn a lot of money from. It's something that people see quick, fast results from, and it's something that the patients are asking for. But the same with aligners, we can give the patients a lot of trouble if we do the alignment treatment in the wrong way.
Exactly. I guess we're going off on a tangent here, but it's an interesting discussion because we're getting away from your specialty in implants, but more to diagnosis and treatment, and then also patient expectation. So during that, what you were just telling me then, and I have a coaching client who had a patient who was missing a canine, and so they opened up a space for a canine, but then the patient decided they didn't want to have an implant there. And so the dentist said, "Oh, I'll just do a bridge." And I said, "But a lateral and a premolar isn't going to be able to support a canine pontic long term. The force on the lateral." There's something I learned very early with bridges is that it's not 1.5 on each. It's actually really, it's 3 on one and 3 on the other, depending on the force they put on it. That lateral will be screwed out of that head in time. The forces of physics have to be considered, not just, oh, there's space there, let's put a bridge there. The other thing, Nicole, is that with my experience in dentistry, it's like you've heard the story that if somebody wins the lottery, there's a fair chance that in 2 years all the money's gone and they're back with the same rotten life they had before they did the lottery. It's the same in the mouth. Sometimes what caused their mouth to be so bad that they then need implants, all on fours, crown and bridge, they still do the same stuff there and it all just goes bad, and we haven't corrected the problem in the first place. And so when somebody says to me, oh, you can have a bridge to replace a missing premolar or a missing molar, what caused that molar to be lost in the first place is usually what's going to cause that bridge to fail, because they're not going to clean underneath it. So as a dentist, I was very keen on not harming tooth structure for the sake of a quick fix with a bridge, when really an implant was better because it was going to be easier to clean about. But my other thought was, during what you're saying, is that in the US sometimes people want straight teeth and they don't want to go through orthodontic work, so they say, just give me veneers. And so then they have good tooth structure destroyed for a quick fix. So how do you then, obviously there are some people who think like me that an implant should be the solution for a single missing tooth as opposed to a bridge, because now we can make it aesthetic and also make it functionally easy to clean without causing damage to the other teeth, either just in restoring them, but then creating food traps, and nobody flosses. Nobody out there flosses like they should. Nobody.
I think the Swedish patients floss. I hope they do.
Well, I'm taking over your podcast. I'd learned that when I asked my patients, "Do you floss?" they actually said they were actually answering a question in their mind. Yes, I know what floss is. I know where it is in the supermarket. And so then I said, the only way to get the answer that you want is you have to quantify it specifically. So I asked my patients, do you floss 14 times a week? Because even if you ask, do you floss daily, that means, daily, 1 day every month. So you really have to get them down to, do you floss twice a day? Even that, they go, yeah, I do that occasionally. But if you say 14 times a week, now that's a long time. And so they go, oh, not 14. And I've got friends who say, I just floss once a day. I say, well, why not twice? Why not 3 times? And so I don't believe that the use of floss is anywhere near what it should be.
No, probably not. No, you're right. I think the patients are very good at doing what we tell them to do in maybe a week or two after they paid money to get their new prosthetics. But then I think they tend to do it fewer and fewer times, and maybe they forget. And that's also why they need to come back on a regular basis to the dental hygienist to get reminded and to see what's wrong.
I know. I've only got 4 restored teeth in my head, but I didn't start flossing until I got my first crown, and that was because of a cusp fracture as a result of an occlusal amalgam that was placed not centrally. And so I thought, I've got margins in between my teeth. I need to start flossing. And I didn't even know what floss was when I started dental school. And my mother took us to the dentist every 6 months. So that was even the education I was having. But anyway, that's it. That just goes to show that no matter how smart we think we are, sometimes people don't follow the lessons that we tell them that they should be. And it is disappointing. You can do a full mouth rehab on someone and they'll never come back. And they go, oh, you're too far away. And you go, shouldn't you be getting it checked?
Mm-hmm. Yeah. Now, that's also something that we need to explain to the patients, what the risks are of not having their teeth checked. There are a lot of studies that have been done on when an implant doesn't success over time or survive. And one of the factors is actually that you don't go regularly to the dentist. And that's I tell my patient that is actually a risk factor for your implant not surviving over time. Because if there is something going on, we need to find it early and not after 5 years or 10 years, because then it might be too late to do something about it.
Well, I started painting even grimmer stories, because they've got to come for their reason, and their reason has to be that everything will be worse if you neglect it. Most dental patients believe that inside here is the same as cleaning the garage. If you don't do it this week, it's going to be the same next week, next month. Nothing much is really going to change in there if I just walk past it. But in here, everything gets worse with time, and nothing gets better with time. Maybe the TMJ does remodel in 75% of cases in 5 years. But other than that, the pockets get bigger, the caries keeps advancing, and people keep feeding it with chocolates and soft drink or soda or whatever they call it, depending on which country you're in, and they just don't clean their teeth. And I stayed overnight at a friend's place. We went to a sporting event, and he said, and we went for a walk in the morning. He said, "You brushed your teeth first thing in the morning when you got up without having eaten anything." And I said, "Yeah, because I've got a dry mouth and the plaque just keeps building up." He goes, "I never knew that." So there's a man in his 60s, educated. Not only did I brush, I mouthwash.
Yeah, you get surprised sometimes.
So it's just, sadly, as dentists, we can only do what we can do. We can't follow people around and stop them from buying chocolates and lollies and rubbish and consuming those. But those things don't jump into their trolley. They don't jump into their mouth. And that's the problem. That's the problem. There's too much temptation. Comfort food.
Yeah,
So
it is.
So when you're talking to them about why they need to come back for the implant, it's just telling them, if this fails, it's going to be worse. What we're going to do is going to be worse than what you've had this time, in terms of it's going to be harder. It's the same as selling a root canal instead of, or selling a filling or a crown instead of selling an implant. Nobody wants to have cow bone put in their jaw and then a bolt put in their jaw. So they'll take the crown easily if you give them those two alternatives. And so the alternative of painting grim pictures is what we need to do. So people only come back for hygiene visits, not because it's a 6 month and they're due. That's our reason, not theirs. It's got to be because we want to check that implant, we want to check the bone loss, we want to check the pocketing, we want to check the mobility. Then they'll come back. But it's got to be in the notes as well, so that when they ring,
definitely.
It's hard
But
work.
in Sweden we have a very good history of working with prophylaxis. Yes. And we, like, for the children, all the children in Sweden have free dental care. It's been up until the age of 24, but now they're actually lowering it to 19. And for the last 30 years or something, all kids have been called to the dentist every second year. And if they don't show up, if you try to get them in 3 times and they don't show up, you are obliged, you have to report them to the social authorities, because it actually counts as child abuse if you don't take your child to the dentist. So we're working hard on prophylaxis in Sweden, which I've always been really proud of that. And I think it's built into our heads, even though we're not even the part of the population that are not dentists know that you go to the dentist every second year. And so this is quite a good learning way.
I think that's great. And a friend of mine once said to me, a dentist friend of mine, he said that we would solve childhood decay if in schools every lunchtime they brush their teeth as part of, when the bell rings to come back to class, everybody brushes their teeth. Because I am married to a school teacher. My wife's was a school teacher, and everybody knows that the kids pay far more attention to what the school teacher says than what the parent says. And they'll come home and say, I got to brush my teeth because Miss Brown, the teacher, said I have to. The dental profession in Australia, and it's probably the same worldwide, or Western world, first world, is the envy of all medical-based treatments, because we've already established this. You've got to go to the dentist every 6 months. Everybody knows that, whether they go or not. I've got friends who are pharmacists. They say people take 1 or 2 antibiotics, pain's gone away. They never finish the full course. And of course, we've seen the obesity shading across America over the decades as time has passed, that the whole of the United States is now shaded dark blue. Every state is obese because people are just consuming too much food and not moving. So they're consuming too much and not moving. And yet their attitude to that, on the whole, is, well, I've paid my taxes, the government should fix it when I have a problem. And I think that's also something that dental has when government pays for dental, people have that responsibility. And then they say, well, why doesn't government pay for dental? Mm-hmm. So sometimes it's really hard to knock sense into people who are meant to be intelligent either. So it's about health and well-being.
Yeah, definitely.
Well, Nicole, we're getting towards the end of our time. Thank you very much for being a guest on the Ultimate Dental Podcast. If somebody wants to get in touch with you, what's the best way?
The best way is either you can find me on social media, on Facebook or Instagram at Nicole Winitsky, or I can be emailed at nicole@winitsky.net, or you can go into my webpage, which is nicolewinitsky.net.
All right, perfect. Well, Nicole, thank you so much. Thank you for getting up early and being a guest on the Ultimate Dental Podcast. And I look forward to following your adventures on social media and in the dental journals and your speaking around the world and also your further education. It's been a pleasure having you as a guest. Thanks so much.
Thank you so much. It was a real pleasure to be with you.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favourite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth, your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, keep smiling, keep striving, and keep on tuning in to the Ultimate Dental Podcast.